So I'm not used to talking to engineers apart from when they've usually been men who are the partners of women with breast cancer. And strangely, engineers turn out to be some of the most supportive partners of breast cancer patients amongst all professions, which is kind of surprising. None of the medical students you see in this photograph are turned out to be surgeons. I think one of them went into anaesthesia, one into general practice, and the tall blonde girl dabbled in surgery, but mostly it's the engineers who come in looking for surgery. And I thought I should start with giving you an idea of the variety of people we see in medicine, right through from people right out on the end of the Asperger's spectrum to people who are incredibly insightful and intuitive and in touch with their patients' emotions. Engineers lie along that spectrum in all kinds of places. Most of the engineers will sit at the back of the lecture theatre. In a lecture theatre like this, they'll be the ones who are going to be surgeons sitting up the back. And to give you a flavour of how we recognise them, one of our senior lecturers, a female, was telling the students, there is an exam on Monday and it is mandatory, so you'll have to be here. If you can't make it, you'll need to bring a letter from your GP. One of the engineers put his hand up and said, if I come with a letter from my GP saying I can't attend the exam because I've had a weekend of torrid sex, will that be acceptable? And she waited for the students' laughter to subside, and she said, you can just write with the other hand. I noticed as I came down from Sydney that Qantas is now promoting a refreshing approach to flying, that their pilots don't just fly planes, it's not just about the technology, they also fly people, which is a kind of interesting take on it. And I wonder where that's going, but it's the theme for what I'm talking about, is the way medicine has grappled with the notion of advancing technology and educating patients about what that technology achieves and how we manage when the technology doesn't deliver the result that everybody wants. You can trace the way society reflects on doctors by looking at the evolution of the TV doctor. And some of you may remember back in the good old days of Ben Casey and Dr. Kildare. These guys were morally upright, very competent, engaging human beings, and both very sexy, and that's what made them quite appealing. Then they were replaced by Marcus Welby, and instead of focusing on the technology and people working in hospitals, Marcus Welby was about doctors covering the whole panorama of life and helping in all kinds of situations. Unfortunately, Marcus Welby was an incredible misogynist, and he was not interested in what the patients had to say because he knew better. He was the God doctor. Then we moved on from that to MASH, where you found doctors who were struggling hard to achieve in an environment where the administration, represented by the Korean War, was actually holding them back. And then you come full circle to today. We've gone past full circle, where you come to House, a drug-addicted person who solves patients' problems very, very effectively on a whiteboard and doesn't need to engage with the patients because he has minions who go out and collect all that data. So this is an interesting kind of panorama of how society's reactions to doctors and what's worked on TV has evolved over years. I'm not going to put much statistics in this except this one slide, which is a photograph my son took in Guyana. And you can see it tells you here, population 562, feet above sea level 2,150, established 1951, total 4,663. I'm going to be talking about uncertainty and how doctors deal with that and how they discuss that with their patients and then how they move on when things aren't delivered the way everybody wants. This is data from the Medical Defence Union in the UK. 80% of the increasing number of legal actions are the result of cosmetic surgery. Not people coming because of something that is broken that they want fixed. A breast cancer, for example, they want repaired, but they're coming because they're not satisfied with a situation that they've been presumably born with. And what you see is the quote from the MDU at the bottom, a huge rise in both the number of procedures and patient expectations of a perfect outcome. That's one of the challenges that medicine has to deal with. When people actually are so dissatisfied that they sue doctors, we know from the literature that these are the predominant emotions that drive their behaviour. They're angry, They're angry, they're bitter, and most importantly, they feel betrayed and humiliated. And the betrayal and the humiliation is about a breach of the trust between doctor and patient. There was a consenting process that gave the doctor permission to actually do something which would, in any other circumstance, put that person in jail because it's assault. So you give somebody permission to assault your body, and then if that trust feels like it's been breached, people feel betrayed and humiliated. That's a common theme of what runs through the ways we manage open disclosure. And out of that literature comes 3 key issues that patients want to have addressed when something has gone seriously wrong. Even not seriously wrong, even the trivial misadventures are things that patients want to have these 3 things: an explanation, an apology, and reassurance. That's a summary of all the literature on what patients say they want. Let me give you 3 examples. When I was working with the Australian Commission on Safety and Quality in Healthcare, I went around the country and interviewed people about their experience of adverse events. Explanation: a delightful oncology nurse working in the cancer area had metastatic bowel cancer, and she presented for her chemotherapy one day. Because she was a nurse, worked in that environment, she was exquisitely anxious. The nurse who was actually setting up her chemotherapy drip forgot to give her the antiemetic, the medication that stops her vomiting as a side effect of the chemotherapy. So the nurse forgot to give the medication. This particular nurse patient vomited copiously on the floor in front of patients. As a professional, she was appalled at the embarrassment and concern she might have called for the patients who were sitting around her. The nurse told her the reason she had vomited was she was so anxious and she really needed to find a better way to manage her anxiety. She didn't turn up for the next 2 chemotherapy sessions because she was so embarrassed and so appalled at the thought that something she'd done might have caused us. So an explanation that was wrong, that was designed to cover up a misadventure, actually caused enormous distress to that patient. The apology is a story I sometimes find quite difficult to tell because it was heartbreaking, and it comes from Western Australia. Quite some years ago, a couple presented with a baby who was fitting. The registrar on call in paediatrics was in his first week, and he gave an anti-epileptic drug. Unfortunately, he gave the adult dose, and he shifted the decimal place. And so the baby was given a massive dose of the anti-epileptic medication, and the baby arrested. And the mother recalls sitting outside the curtain and seeing flashing arms and moving equipment as people tried to save the baby and failed. 10 months later, she told me she was at the coroner's court, and she joined the queue at recess in the ladies, and turned around, recognised a woman behind her. She said, "You're one of the nurses." And the nurse said, "I'm the one who pushed the plunger." And she said they both burst into tears and fell on each other's shoulders. And she said it took 10 months and the ladies' toilet queue for me to realise that the people who were with my baby when she died were not monsters. So one of the key things that I learned out of that story, and others like it, is we have to try and bring people together when something goes wrong, because human nature is actually most often trustworthy enough to the point that people can be relied on to want to heal that breach. And the reassurance, another story of a patient in Sydney. The radiation therapy team were treating her breast cancer and got the radiation field horribly wrong. They burned a hole right through her chest wall, through her lung, and she now has a fistula, which has to be a hole, which has to be drained regularly. After I'd interviewed her, I recorded each of these patients on video. She said, "Before you go, let me show you something." And it was an article in one of the thoracic medicine journals, an article about her case. And she said, "They've written up my case, it'll never happen again." And for her, that reassurance actually brought some sort of closure to the whole experience and almost made her suffering of value. So patients want to know exactly what happened. They want us to be honest and open about that with what we know at that point. They want to know that we are suffering too, and they want reassurance that we are learning as a system from it. So the closure is a key aspect. I often wonder, I haven't got an answer to this, if closure is a sense of resolution or conclusion at the end, what is disclosure and what is open disclosure? Let's look at how doctors respond, because doctors and nurses are the second victims in these sorts of situations. Doctors respond according to the literature, and this is just one study, with this cascade of emotions: self-doubt, disappointment, self-blame, shame and fear. All of the things you would think about. Fear for the patient, fear for the outcome for the patient, fear for themselves, fear for their careers, disappointment in the fact that they've not performed at a level they expected they would perform. So all of these things cascade, and what they achieve is the doctor wanting to be as far away from that patient as possible because it's so painful to review what they've done. It's important not to underestimate how powerful these emotions are for doctors and nurses, any health professional involved in adverse events. People suicide when they actually think there is nothing they can redress, nothing they can recover. So there's a process of reaching out, and all of our efforts around open disclosure in medicine are designed to try and find ways to bring patients who want to heal the breach back together with doctors and nurses who are alarmed at what they've done. One of the problems is it's very difficult for anybody, any of us sitting in a consultation with a doctor, to get their attention. So you can try, like this guy, coming in starkers. Starting the consultation nude is probably one way of doing it. But one of the projects we did at Royal Prince Alfred Hospital in Sydney was record 298 consultations, and we had this delightful visiting student who we coerced into going through each one of the records of these consultations and recording a cue the patient gave the doctor that there was something they didn't understand. A cue they gave the doctor that they were feeling something about what had been happening to them. And overall there were 11 questions and 2 cues, 11 direct questions and 2 cues. Haven't been sleeping too well the last couple of nights. If the doctor doesn't respond, I'm wondering whether I'm feeling a bit low. And you can see that doctors don't do terribly well. These are oncologists. If you look at the red numbers, doctors responded to 72% of the informational cues, but only 28% of emotional cues. So most of us, if you sit with your doctor and say, I'm not feeling terribly happy, the doctor will bypass that, mostly for good reasons. They feel if I open that, it's a Pandora's box, that's not doing any benefit, I don't have the time or the skills to address this, better I park that and deal with your clinical, physical needs. One of the really important studies that we think we've used to contribute to doctors understanding that there's a better way is this one, where we looked at some 300 patients attending routine cancer consultations. And we divide them into 3 groups, randomised: a control group, one group who was given a prompt sheet, questions you might like to ask your doctor that are in the highly charged category. Am I going to die? Is this treatment going to cure me? Is there anything I should do or think or feel that is going to improve my chances of survival? And patients were given a prompt sheet and said, ask your doctor. And then we divided the doctors, and we had one group who were told to proactively take the sheet from the patient and go through the questions at the start of the consultation. And when they did that, you see patients recall. We called them 10 days after the consultation and asked them for feedback about what they'd learned. We asked them specific questions. Did he mention chemotherapy? Did he say it was this particular name of drug? So patients were prompted for recall recognition. And recall was 25% in the control group, doubled in the group where the doctor at the front of the consultation actually addressed the patient's emotional agenda. Then we measured anxiety when the patient exited the consultation, and again that was lowest where the doctor had addressed the patient's emotional agenda, but most importantly it was more efficient. It's almost like if you clear the emotional clutter off the desk, the patient actually hears better, feels safer, and it's more efficient for both doctor and patient. So we're trying to actually convince doctors now it's worth taking the time to put the patient's emotions on the agenda because it will actually be more efficient long term. Can I ask you just to think about these 2 questions? This is a workshop we do before we actually do actor-based workshops with doctors and nurses. Think about how you would solve a problem which needs to be solved. It's important. Some of us will actually think, plan and analyse very thoroughly until we make sure that we've covered all the bases. Others of us will leap into action, look at the problem, decide on a solution, try that out. If it doesn't work out, come back. So we divide people into those 2 groups. Then ask yourself the second question, what's your data for making decisions when you have a big important decision to make? Is it feelings, instincts and intuition, or is it facts? Things you can see, things you can touch, things you can read. And has everybody got an idea of where they fit in one of those 4 quadrants? Yes? That's fine, thank you. So these are very interesting because it actually highlights the different ways doctors think and the different ways patients think. So a reflector this is where all doctors go to take a history. Take your time, the patient's instincts, your clinical instincts are all important. So this is where all doctors go to take a history. Once they've elicited the history, they then use templates to match the patient's presentation with diagnostic categories. So here are 5 cardinal signs and symptoms. This is my template for a fracture, doesn't fit. This is my template for HIV, doesn't fit. This is my template for breast cancer, perfect match. Therefore she has breast cancer. So this is where PhDs come from. And then you go to the pragmatist, which is your orthopaedic surgeons, or anybody who says, I can fix this, I've got a hammer, I'm looking for nails. So the pragmatist says, she's got breast cancer, she needs surgery, chemo, radiotherapy, because that's the best practice. That's the right way to treat it according to research, and patients love them because they feel safe. And then you have the activists, people who are good at getting into the patient's situation and actually saying, I understand how you feel about this situation. This is where you build rapport. One of the core issues that we've seen about the mismatch comes from a study in the UK, a very large sample of doctors. 31% of their doctors preferred the theorist mode. They like to think in terms of facts. How can I explain that to the patient? And they have 1 in 11 chance of seeing a patient who actually thinks about the world, thinks about their medical situation the same way. Reflectors, 40% of patients go into a consultation thinking, I need to solve this problem by understand feelings, instincts, intuition, and I need to talk to you about those things, and they have 1 in 6 chance of seeing a doctor the same. Guess who are the best people for dealing with the explanation component of open disclosure? It's the theorists, and we find in workshops that if you put a theorist in front of a patient after something has gone wrong, the theorist does a really good job of explaining, but they forget the apology. The apology is the domain of the reflectors and the activists because that's where they instinctively work. And the pragmatist, of course, is the person who looks at systems and how we can repair the system, and so they go directly to provide some sort of reassurance. The big problem we have in medicine is things are just changing so fast. Doubling time of medical knowledge has decreased from 50 years in 1950 to 0.2 years, 73 days in 2020. So what we teach our students now, about 6% of that will be applicable in 2020 when they graduate. And of course, in the healthcare system, we're trying to do this. We're offering 3 kinds of service, good, cheap and fast. And you can't do all 3. Robert Lister was a famous surgeon in the 18th century who did all 3. He was amputating patients. He held the record for amputating a leg, which was 2.5 minutes. In those days, there was no anaesthesia, there was no antiseptic, and so amputating fast was really critical because otherwise the patient would die from shock and blood loss or they'd die from infection. He was renowned for having a 300% mortality in one of his operations. He actually lost the patient died of gangrene. In slashing about, he actually hacked off the finger of one of his assistants who also got infected and died, and one of the observers got his coat slashed and he went into shock and arrested and he died. So 3 patients died out of 1 operation. The point of this story is Liston started out doing something with the best interests of his patient at heart. He was patient-centred care. If I operate fast, I can actually reduce mortality. And he did, reduced his mortality from 40% to 10%. But as he became more and more expert in these, it became a presentation. You would walk in, you'd sit in a theatre like this in the round, the patient would be wheeled in, the great man would come in, and he would turn to the audience and say, "Gentlemen, time me." And then he would go. So his motivation had gone wrong. Misdiagnosis. A colleague of mine is an eminent oncologist, 700 publications in the best quality journals. He presented with a Horner syndrome, which is a droop in the eye, which can be associated with a dissection of the carotid artery. The artery starts to unravel. If that happens, you have a 30% chance of dropping dead instantaneously. He saw his neurologist. The neurologist said, I've looked at all the scans. We can relax. It's not a dissecting carotid. 3 days later, he came back and said, I made a terrible mistake. I misread the scans. It is. And my colleague said his trust in that neurologist went through the roof. He knew that whatever happened in the future, this doctor would always tell him the truth. So it was about maintaining that trust and how that had been built up as a preamble. Another colleague of mine was sued, a colorectal surgeon, for one of the adverse events that is known in colorectal surgery. During the course of the litigation, he got a call from the patient, which he thought unusual, and the patient said, "My GP says I have another lump, I will need more surgery." John said, "But you're suing me," and the man said, "I have to sue you to get compensation, I wouldn't go to any other surgeon." Amazing. As a consequence of that, John thought very hard about how he informs a patient before the surgery. And what he does now is he sits down with the patient and he draws just a diagram of where he's operating, and he says, "What I'm doing now is showing you the area where the nerve that supplies your penis runs. I have never cut that, but better surgeons than I have done so. If that happens, you will become impotent, and you and I will work very closely together to manage that. I'm telling you this to remind you that this is a serious risk. It's very hard to see that nerve, and to remind me to be extraordinarily careful when I'm dissecting in that area." So basically, informed consent, sharing that process of what we're doing and maintaining the doctor's motivation to do this for patient-centred reasons is what I think keeps people safe, and why, in fact, given the large number of interactions between doctors and patients and the much smaller number of ones that lead to litigation, it is actually quite small. Patients are forgiving. So in summary, it's about risk management and it's about safety, and I hope what I've talked about is relevant to you because you're an audience from quite disparate areas. It seems to me, certainly in medicine, that human relationships remain the core element we have to address, and that we haven't actually worked out a system where advances in medical technology, we've explained these to patients so that we have a parallel investment in education of not just patients but also professionals to realise that the technology changes the way we view things. And finally, that open disclosure begins with informed consent. It's about a relationship, and it's about the way we manage that relationship from the first time we have contact. Thank you.